There are mammography and ultrasounds, and to complete with additional imaging. We already heard about second look ultrasonography. Often when we perform MRI, we have to go back to ultrasonography. And also, if we haven't found the lesion, the previous ultrasonography, if we know where the lesion is, because MRI told us, if we know how is the lesion, how big is the lesion, it's much easier to find it. Category 1, no disease. So it depends on the indication of the examination. We can continue with the routine screening. The same with benign findings. With category 3, it means probably benign. We'll talk about it. Suspicion of abnormality, category 4. Category 5, high suspicious of malignancy. And category 6 is the category when we already know that there is a lesion into the breast, but we need MRI to stage a virological staging of the disease or to evaluate the contralateral breast. So looking at MRI, we can find abnormal enhancement. You know that we can see the lesion thanks to the enhancement because especially malignant lesions are hypervascularized and the contrast media injected intravenously consent us to see the lesion. The lesion can be a focus or a foci. They can have a pattern as a mass or as a non-mass-like enhancement. What is a focus? The focus is a tiny, very, very small spot of enhancement, too small to evaluate shape and margins, without any correspective brain contrast image. So often, unfortunately, we find images like those. Sorry, this is the big lesion, but a lot of tiny spot enhancement. Sorry, it's very difficult to say if they are a lesion or if it is a normal parenchyma. And the focus, we intend a lesion that is less than 5 millimeters in diameter. Foci are multiple spots of dots of enhancement, and usually they are considered incidental enhancing lesion. When we speak about focal mass, it's a 3D mass, it's a 3D lesion. We evaluate the shape, the margin, and the internal enhancement. The shape can be round, oval, lobular, or irregular. We'll see some example. The margin can be smooth, irregular, stipulated. Internal enhancement can be homogeneous, heterogeneous, with a rim enhancement, with septa inside that can enhance and not enhance, and with a central enhancement. Malignant sign could be irregular shape, with a PPV of 84%, the spiculated margins, and also the rim enhancement. Sign of benignity could be the smooth margin and also the non-enhancing septa into the lesion. Some example, the shape can be round, oval, lobulated, irregular. You see, this is a round mass, this is a lobulated mass, and the margin smooth, irregular, or spiculated. This is a classical example of spiculated and here irregular margins. And all those signs are important to decide if the lesion could be benign or malignant, to characterize the lesion. Again, we have already seen non-enhancing lesion, as in this case. Here we have an enhancing lesion here that has an heterogeneous enhancement. We can have some lesion with rings around. You see the rings around. This was a case of recurrence multifocal recurrence, and this was a fibroadenoma. Again, non-mass-like enhancement, so no 3D lesions, but lesions that doesn't occupy space. They can have, we look first of all at distribution, focal area, delinear, ductal, segmental, regional, multiple regions, diffuse. Sometimes it's not so clear if they are one type or the other type, but it's just to understand that we see a lesion like this one is not a 3D lesion, or an area of enhancement like this one, some small spots together that they can be a sign of inside to carcinoma, ductal carcinoma. Another region, ducts, this could be segmental, and so on. This is a case where you see a typical interductal lesion that follow exactly the region, the area of ductal in a lobule, in a lobe. But also the non-mass-like enhancement can have an homogeneous, heterogeneous, and scattered and steeple, punctate, foci, and reticular dendritic aspect. You see this area of enhancement, on this one, and a lot of spot around all over both of the breast. Looking at the enhancement, we have we can calculate the signal intensity curve. At the beginning of the history of breast MRI, we thought that the curve would be the most important indicator for benign or malignant characterization. Now we take care more than morphology and margins than curve. Also because we have something also better than curve as, for instance, DY, diffusion imaging. Anyway, this is a typical curve for benign lesion. This is the intermedium curve. That's type 1, type 2, and type 3. And we know that because of the high vascularization, often the cancer has a curve like this with a very rapid enhancement and with an effect of a washout effect because the contrast medium goes away as quickly as he went into the lesion. Looking at the literature, sign of benignity, non-irregular shaped mass and smooth margin, no enhancement of homogeneous enhancement, no washout curve, no mass steeple enhancement. Those are signs of benignity. I mean, if you don't see those signs, the lesion could be probably benign. Typical for malignity are irregular shaped, heterogeneous enhancement, washout curve, non-mass clamp, ductal or segmental. And again, we know that the most frequent morphological findings in malignant lesion are following this paper: heterogeneous internal enhancement in delayed phase, 96%, or heterogeneous internal enhancement in early phase, 90%, washout curve, 64%. Benign lesion, the most frequent morphological findings are smooth margin and curve type 1. Again, the predictive positive value, the value is oval shape 88%, delayed internal homogeneous enhancement 87%, and dark internal septation 86%. So if we find those signs, most probably the lesion will be benign. The same for malignancy, greater margin, delayed internal enhancement, are the most important sign, and then irregular shape and the light enhancing internal septation. In the last Bayrat's report, they underlined the important role of T2-weighted lesion because of T2-weighted images, and they demonstrated that about the 87% of cancer are either hyperintensity 2 and bright 2 might help to assess malignity, hyper-T2 in fibroadenoma in patients less than 50 years old. And also there is a limited value to do overlapping bright, so in signal intensity, mucinous and medullary tumor and in lymph nodes. So we have to take into consideration that we don't have a technique that can consent us to say that it's benign or malignant. We can just suggest the characterization. And fortunately, it's easy usually to go to the biopsy to have the right characterization before to send the patient to the oncologist or to the surgeon. I think it's not in Bayrat's, but I think it's very important to report also, if you are able to, the data of diffusion weighted imaging. That is a parameter becoming very, very important. Anyway, to conclude, Bayrat's 0 means incomplete assessment. In this case, we went to second look ultrasonography to understand if this lesion that could seem an insight to carcinoma, to understand that there was an error of cystic disease at ultrasonography, so a benign lesion. Bayrat's 1, no disease, so the normal parenchyma often in the last acquisition can enhance, but usually in a homogeneous way, bilateral. 2, the classical benign lesion are fibroadenoma that often doesn't enhance, but if enhanced has this morphology, oval and with very clear margins. This is a cystic lesion. We know that with T2 weighted images, we see a bright image that doesn't take any contrast media after the injection. This is the T1, so we see a black area corresponding to the cystic T2 weighted image and nothing at the subtraction. The problem is the Bayrat 3, as usual. Probably benign findings, but we are not too sure. Sometimes we need a short interval follow-up is suggested, and is a topic that needs a lesson alone. I mean, this is an example of probably benign lesion. It's too small to decide if it's benign or malignant. The morphology is not so regular. It's the only small enhancement. So they suggest a short interval. So it depends also in the story of the patient, because if the patient is high-risk patient, I think we have to go straight to the biopsy under MRI. Bayrat's 4, Bayrat's 5, Bayrat's 6, suspicious, highly suggestive of malignancy, known biopsy as I told you before. Some example, this is a Bayrat's 4, because the cure was not typical for malignant lesions. It seemed to be a cancer because it's round with speculated margins. It was a adenosis at the biopsy under MRI. Bayrat's 5, irregular mass, irregular margins, central necrosis, fast enhancement, and washout. So this is a classical image of malignant lesion. And this is Bayrat's 6. At mammography, we saw a very huge lesion behind the nipple and the posterior profile of the glandular tissue, and at MRI you see very well other other foci of lesion. It's a multifocality lesion. And I think slides and lexicon are finished. Thank you for the attention. So unfortunately, I have to
I think we can move on to the second lecture.
I think it's the Osama one. It's the Osama one.
Recommendations for breast MRI education.
Thank you. So Osama is the European Society of Mastology. That is a society where are together oncologists, radiologists, radiotherapy surgeons, and so on, people working in a multidisciplinary team. And about 3-4 years ago, we met in Milano to write a document with a recommendation and suggestion on the use of breast MRI. Because we understood that if you don't use correctly the MRI, you can cause damages to the patient and also to the other surgeon, because often when MRI is not indicated, you don't have any benefit. You have to perform MRI only when you need it. And this is the paper. And what we need for a useful MRI: expertise in breast MRI first, but also expertise in all breast imaging techniques. I every time say that you can be a good expert in breast MRI if you don't know the traditional imaging in breast. Correct timing, because we have to perform the examination at correct timing. We see examination quality, correct indication, correlation with traditional imaging, correlation with single patient profile of risk, and common sense that is not so usual in medicine and in radiology. And then, if we need MRI guided breast MRI, where possibly in a radiology department in a breast where there is a breast unit, because often we have to decide together with a surgeon and oncologist if to perform or not the MRI, if it could be useful or not. We need experience in conventional breast imaging. We have to perform at least 150 examinations per year, and if it's possible to have also a procedure for the biopsy. Otherwise, we have to link our center with a center with this possibility. When we know that the best period for the MRI is from the 6th to the 13th day of the menstrual cycle, even with oral contraception that are not any contraindication. But in case of hormonal replacement therapy, we have to stop at least 4 weeks after discontinuation and the treatment. How? With a good machine, that it could be 1 Tesla could be enough, but you need a bilateral dedicated coils, preferably multi-channel. You need a contrast-media injection, intravenously injection, and the exam has to be simple, reproducible, and accurate. Because at the beginning we started with tailored examination, but then they are not good, totally unuseful. The exam has to be the same, and the patient can be to other centers and the same exam, made in the same way. Indication: staging before treatment planning, screening of high-risk women, evaluation of response to neoadjuvant chemotherapy, patients with breast augmentation or reconstruction. That has been the first indication at MRI, also before the introduction of contrast media, occult primary breast cancer and breast cancer recurrence. I'll talk later about the staging before treatment planning, so you can just know that MRI is better than mammography and ultrasonography in staging, but we'll see in the next talk. About the screening of high-risk women, we already heard about it from the previous communication and the previous lecture, but the recommendation are that to perform an MRI annually in BRCA, BRCA1, BRCA2 mutation carriers, in the 50% of risk for BRCA1, BRCA2, also if you don't have the test. So not tested or conclusively tested for BRCA1 with lifetime risk, as they told before, from 20 to 30, a previous mental radiotherapy before age 30, and with high risk, with history of breast cancer should be included in screening programs with MRI. If annual MRI screening, ultrasonography, and clinical breast evaluation are not necessary, I mean, we are deciding in Italy to start mammography in high risk from 35 and study only with MRI only till 35. But we need ultrasonography only if MRI is positive, otherwise it's completely unuseful. This is an example of a patient with a mutation, nothing different from other patient without mutation. Another indication is the follow-up of the neoadjuvant chemotherapy. We are speaking about the adjuvant therapy in this Congress because it's becoming more and more important. And years ago we understood that MRI is the best technique to evaluate, to follow up the therapy, because it is better than mammography and ultrasonography in dimensioning the results, but also during the treatment you can have early information and decide if this drug is not good for this cancer. You can change, you can stop the treatment of chemotherapy thanks to the information that you can have from the MRI. The recommendation does not have a role in the assessment of treatment options, so we don't decide if the patient needs neoadjuvant chemotherapy because of the MRI. It's a clinical evaluation indicated post NAC 2 weeks after last neoadjuvant chemotherapy cycle, within 2 weeks before surgery, caution in patient treated with taxane and bevacizumab, because we know that sometimes we have false negative in MRI because it's better than mammography and ultrasonography, but in some cases you don't see any residual lesion, but there are still some cells, Hill cells, so there is still cancer in that area. Negative MRI after neoadjuvant chemotherapy does not exclude residual tumor, that's I told you. The first indication was the evaluation of implants. I will speak about the reconstruction, the evaluation of the reconstructed breast later. But this is a very good indication, and you can just understand that it's easy to recognize the rupture of the wall of this silicone one shell implant. You can easily see that there is blood and serum behind this implant. We saw something with ultrasonography, but no more than some liquid behind the prosthesis. You can see very well all the pattern. And in this case, you can see silicone outside the prosthesis. The recommendation, breast augmentation for oncoplastic reconstruction, are recommended in asymptomatic patient as a routine surveillance. It's recommended for high-risk groups that would qualify for MRI screening. I mean, if the patient hasn't high risk, you don't have to organize a follow-up of operated patient with MRI. Is recommended for higher, is indicated in symptomatic patient if conventional imaging is negative or equivocal. Beware tissue expanders because sometimes they are not compatible with MRI. Another indication, very interesting, is the occult primary breast cancer. MRI of the breast can identify occult breast cancer in about 50% of the patients. that have previous traditional imaging that was negative, may facilitate breast conservation. If negative, breast MRI predicts low tumor healed at mastectomy. This is a case, a very big metastatic lymph node in the left axilla, and this is the MRI. It's unbelievable, but this was the little carcinoma, and was about 5 millimeters in diameter, with this large metastatic lymph node. We found this lesion with a second look ultrasonography. It was easy to make a core biopsy and have the diagnosis. We had it about 15 days ago at our hospital. In case of CAP syndrome, as I told you, it could be a very important therapeutical but also psychological trouble. The patient knows to have a metastatic cancer, but it's not possible to identify and to see the cancer. We know that probably it's a breast cancer, but we can go to surgery as usual. There are some theories and hypotheses about CAP syndrome, one that there is ectopic breast tissue in the axilla, and we think is metastatic lymph node, or there is some breast tissue inside the lymph node. Or another theory is that the primary cancer has been controlled by efficient immune response, and a more aggressive clone develops in the axilla. So if the therapeutic approach in case of CAP syndrome can be from mastectomy to watchful waiting, but in Italy, and there is also international literature, they find that the right therapeutic strategy is to proceed to axillary dissection and breast irradiation. Those are the results of literature about CAP syndrome. As you have seen, as I told you, about the 50%, in the 50% of the cases with mammography and ultrasonography negative, we can find a lesion thanks to MRI. This is a lesion, and those are the involved lymph nodes. So I already told you that we can proceed after MRI to breast correct treatment. Not always conservative, because sometimes, thanks to the MRI, we have to proceed to mastectomy. There is this very interesting paper in the literature from the Memorial from New York that demonstrated that that there are also false negative at MRI. So they proceeded to 12 mastectomy and with MRI negative, and they found 4 carcinomas. But in the people who didn't underwent mastectomy but only radiotherapy after a negative MRI and the follow-up, they didn't find any breast cancer. So we can confirm that axillary dissection and radiotherapy after MRI could be the best treatment. Again, CAP syndrome indicated, as I told you, there's no time to go on this topic. I talked about enough. Breast cancer recurrence is another indication, is accurate technique for differentiating surgical scar, recurrent tumor. Surgical scar is a fibrotic tissue. Recurrent tumor is a hypervascularized, so it could be easy to recognize, to differentiate both. But sometimes also the surgical scar has inflammatory changes and could be vascularized, so we can have also false positive. The sensitivity is around 100%, the specificity from 89 to 92%. 2 cases, this seems to be a big scar, but is a recurrence, and is a recurrence in all breast. The recommendation indicate if inconclusive findings on conventional imaging, indicate if neither biopsy cannot be performed or is inconclusive, and previous invasive carcinoma or ductal carcinoma do not confer and increase the risk for annual MRI screening. MRI is not an alternative to needle biopsy, and we have to take this very well into consideration, not to consider MRI alternative to needle biopsy. When breast MRI biopsy, we'll talk about tomorrow. Preferably, ultrasound guidance means that if we are able to see the lesion also with ultrasounds, we have to choose ultrasound because it's cheapest and is the fastest and the easiest way to perform a biopsy. A lesion has to be clearly visible at MRI and reproducible, and we'll talk about on it. Page. Anyway, we have to repeat the examination before biopsy if we are not convinced that MRI done in another center is not as good as we would like, or if we are in doubt about the execution of the examination. I don't know, stop it here. Okay, this is just to show you another example. The CIS not visible at mammography, very well visible at MRI. We made a biopsy under MRI, and then we put a clip into the breast under the MRI guidance, so the patient went back to her hospital and she had the intervention, and they were able to, thanks to the marker, to localize the lesion. So how to use MRI to conclude, respecting indication, only with breast unit agreement, high-risk screening, after and with traditional imaging. We need expertise in breast imaging, and it's not alternative to needle biopsy. Thank you for your attention. So I don't know if to continue or if you want to speak about any of you before. Thanks.